مساكم الله بالخير جميعا. تقبل الله إن شاء الله منا ومنكم صالح الأعمال والنيات. المحاضرة هذه as you see the title will be Malignant Eyelid Tumors. حيكون في case based lid reconstruction. It's going to be oral oriented لأنه الموضوع في lid reconstruction is very vast. It's difficult to cover it in one session. لكن the most common lid reconstruction will be methods or surgical techniques will be discussed. لأن كثيرة. We'll choose randomly. بسم الله. Okay, so if any first year resident can tell us the characteristic of malignancy. if you can choose any first year Faisal.
الحين إن شاء الله حيطلعون إن شاء الله.
Oops.
في دكتور ياسر ثابت بس R2.
Okay. أتوقع فيكم.
السلام عليكم دكتور. So the sign that malignancy could be ulceration, chronic non-healing lesion, destruction of the eyelid margin, bleeding from the lesion as well, and madarosis. If there is also central ulcerations, if there is a telangiectatic on the eyelid margin, there's a pigmentary changes. Could suggest a malignancy. This is the sign.
Okay. هذه كلها?
Yes.
Okay. What about the examination? يعني في other things.
So you mean in history, doctor, or the?
Oh, history. Is it typically painful or malignancy?
Can be painful. The pain can be associated with if there is a perineural invasions, and some tumor is painless. It's with pain.
Okay, so you got most of it. Signs are ulceration, induration, irregularity, destruction, non-tenderness is more typical. Telangiectasia, purely border, and the very important sign, tethering to underlying tissue. Okay, what about what are the most common lid lesions in the preorbital area? Malignant.
The most malignant اللي هو basal cell carcinoma.
Okay, what else?
The most common account for 90% of the second most common could be the squamous cell carcinoma. Squamous cell carcinoma and sebaceous cell carcinoma and also melanoma.
Excellent. So let's start with basal cell carcinoma. What's the mode of spread?
Basal cell carcinoma, it's less likely to be spread systematically. It has a local invasion.
Excellent.
Yes.
Okay. What about
squamous cell carcinoma can be spreading systematically through the lymphatic or through the hematogenous spread.
What else?
Also could invade the orbits as well. And also
sebaceous cell carcinoma, it's the same. وميلانوما the same. طيب بس just to
Yes.
be more specific, basal cell carcinoma locally invasive, squamous cell carcinoma is perineural, sebaceous is perineural and lymph node, but I would concentrate more on the lymph node. Okay. طيب melanoma, it's more hazardous because it has tendency to spread through the blood. Okay. So what about the associate? I know this is a rare question and it's more of an MCQ question. So the associated syndromes that accompany such lesions, what are they? What do you know?
يعني مثلا عندنا ميوري تور سيندرومز مع السيبيشس سيل كارسينوما.
Okay, excellent.
عندنا برضو اللي هو other cell which is the basal cell nevus syndrome.
So yeah, with basal cell carcinoma. So
yeah, and pigmented. Yes.
Basal cell nevus usually is autosomal dominant, and if you see a basal cell carcinoma in a young patient, let's say third or fourth decade, you may suspect it. You can read about the associated symptoms and signs. Mortuary syndrome, it's very important to, when you see an elderly patient, to ask about GI bleeding, rectal bleeding, alternating constipation and diarrhea, all of these things, because it's associated with visceral neoplasm. طيب شكرا ياسر. Excellent as usual. طيب بالنسبة لل
شكرا.
This is very important staging system, American Association of I think this is the 7th edition. So we'll talk about that, but I think you should pay focus on the this one and this one, because this will give you more of some prognostic factors, very important prognostic factors. Okay, I need R4. نشوف, let me see, I'll choose. عادة نختار program join, so let's choose KKish or KSU if I recognize anyone. Cannot see anyone. طيب any R4, let's see, دكتور هاجر المريس.
السلام عليكم دكتور.
هلا حياك الله. وعليكم السلام. طيب can you tell me just يعني just a short brainstorming or discussion about the principles and goals when you want to reconstruct an eyelid defect بشكل عام, لأنه I'm going to talk about it in the next 3 slides. So if you have like you removed an eyelid lesion and there is an eyelid defect, what are the goals and principles that you should stick with to reconstruct the defect nicely in a nice anatomical manner? دكتورة؟ هي معنا دكتورة هاجر ولا فيصل؟
Do you hear me دكتور؟
اي الحين اسمعك. طيب فسمعتي سؤالي؟
Can you repeat دكتور please?
So what are the can you talk about the principle and goals about how to reconstruct an eyelid defect يعني بشكل عام كذا discussion.
I would reconstruct either anterior or posterior lamellae, not both of them. I will use the graft if there is any big or large defect.
So if you have a full thickness defect, that means you have an anterior and posterior lamella defect. So how can you, what are the principles that you should stick with?
The principle, I will use the skin graft from the upper eyelid for the contralateral eyes.
لا يعني don't be specific. يعني this is more of I want you to give me goals. مثلا when you read it in any book, there are principles that you should know about.
Principles.
So
I have to
let's say that the lower lid, just to simplify it for you, if you have a lower lid defect, what are the most important things that you want to fix or maintain? You have the eyelid margin, you have the eyelid elasticity or the horizontal laxity, and you have the closure of the same of the anterior lamella and the posterior lamella. يعني هذه الأشياء. Can you brainstorm a little bit?
Again, doctor?
So what other principles can you discuss بعد غير هذه اللي ذكرتيها؟
I have to maximize the horizontal tension in suturing and minimize the vertical tension.
طيب اوكي نواف المقبل is raising his hand, فشكرا دكتورة هاجر. نواف.
السلام عليكم دكتور.
هلا وعليكم السلام.
الله يعافيك. دكتور, we have to develop a stable eyelid margin. We have to have adequate vertical eyelid height, adequate closure, smooth dermal surface for the eyelid. We have to pay attention to cosmesis also, and asymmetry between the two eyes.
Okay. What about the grafts? Graft versus flap.
The graft, we take it without its blood supply.
Okay.
And the
So
flap,
if you have a full thickness defect, what should you do? How can you repair anterior and posterior lamella if you want to use a graft?
first, if there is adhesion, we have to release the adhesions.
Mm-hmm.
We should pay attention to maintaining or providing a good blood supply.
طيب. Can you use two grafts, مثلا graft and graft, or graft and flap, flap and graft?
I think you can use graft on graft, yes.
You can, but this will be devoid of blood supply, both of them.
Graft on graft, no, but graft on flap, yes.
Okay, so you have to have a flap.
Yes.
At least, okay. طيب, okay. Any R1? شكرا نواف. Let's see. If there is any R1. Faisal, if you can choose any R1. في دكتور ابتهاج. If you can unmute.
السلام عليكم.
هلا عليك السلام, حياك الله. دكتور ابتهاج, can you tell me anterior lamella is composed of what?
The anterior lamella is composed of skin and the orbicularis muscle.
Okay, excellent. What about posterior lamella?
The posterior lamella is composed of the conjunctiva and the tarsus.
Good, excellent. طيب, have you heard about middle lamella?
I think it is composed of, I'm not sure, but I think fat, the middle lamella.
طيب, okay, excellent. شكرا دكتورة. So, as you said, anterior lamella is skin and orbicularis, and so basically this one. And the posterior lamella is basically, as you mentioned, tarsus and conjunctiva. However, middle lamella, some surgeon they don't use this term quite often, but it's basically retractors and the orbital septum and fat. And it's very useful to use this term post-filler migration or post-trauma, post-aggressive blepharoplasty, because this is more of a fellow level, but middle lamella is very important to examine and document the first visit. طيب. So just a couple of principles. بس قبل كذا, so each section I will stop, and if you have any question feel free to ask. تمام. بعدين نروح للنقطة اللي بعدها. طيب. So just a couple of principles and goals. So you need to restore both the anatomy of both lamella, as we mentioned, and to maintain dynamic function of the eyelid. You need to have stable eyelid margin with no eyelid malposition, acceptable vertical eyelid height, and you will see this in a couple of flaps I'm going to show you, adequate eyelid closure. So this is maintaining or replacing the orbicularis or approximating the orbicularis to the defect is very important. Smooth the posterior epithelial surface. You don't want the patient to have corneal keratopathy and punctate erosion. Canthal fixation, also this goes hand in hand with a stable eyelid margin. And to try to achieve the maximum cosmesis and symmetry. Of course, as Dr. Nawaf mentioned, you should not use graft to reconstruct both lamella because you need a pedicle flap to provide the blood supply. Tension, and this is, I think all of you know this, you need to close the any eyelid defect, whether it's traumatic or post-resection, you need to close it horizontally because you want to avoid any eyelid malposition. And to avoid vertical tension, I didn't put the vertical, this relaxed tension, skin tension line, but this is more of fellow base. But you need to have good vertical tension, not to, so it will not cause lid malposition. If it's possible to construct a flap, it's better because it looks much better than a skin graft. Not sure if there are fellows in the audience. في أحد? Anyway, because let me go back to the slide. This is for fellows. So and also whoever rotated with me, they know that I like discussing surface anatomy. So in this area, in the pretarsal area, the skin is very attached. So حتى ممكن تقيسونها على نفسكم الآن. تشوفون just below the lid crease at the tarsus, you can see the skin. You cannot pull it. However, above the lid crease here, you can pull it easily. So having skin graft in this area, it's difficult to maintain, subhanAllah, the normal anatomy. So it doesn't look nice. If you can try, this is for fellows or senior residents interested in oculo. If you can try to avoid the skin graft in this area, it would be much better. However, sometimes ما تقدر يعني تتفاداها. تمام. Very important part. So sometimes I'm going to show you a picture of eyelid defect. This is very important point that largely it's based on the surgeon preference. Sometimes the old age helps in having multiple flaps due to increased degree of laxity, and also the location and size. Because so surgeon preference is one of the things that contribute in choosing the best surgical technique. طيب okay, let me see من في أحد من الزملاء. okay, في دكتورة دلال فطاني.
ايوه موجوده دكتور.
كيف حالك دكتورة؟ طيبة؟
دكتور.
طيب this patient came with this lesion complaining of this eyelid mass. Can you tell me how will you manage?
Okay, so we'll start by taking history of the patient when he first noticed this lesion, as it's growing in size.
Okay, so I'll answer each
Okay, sure.
history. So it's been there for 1 year, progressively growing.
And the age of the patient is?
60 plus.
60 plus, okay. Is it painful?
No.
Okay, it's been slowly growing. Okay, does he, what's the occupation of the patient?
Farmer.
Okay, so there's sun exposure, if he's a smoker or not.
Okay.
And then I'd like to go over the risk factors of the age, the smoking, the sun exposure, if he has any other skin malignancies, or he's known to have any other systemic problems. Then
Of course, a visual complaint is also important.
Yes.
By examination, what will you
Okay,
examine?
by examination, I would go to the lesion itself. I would like to see, I can see here there is destruction of the eyelid margin. I can see there's loss of eyelashes, telangiectatic vessels on the lesions with pearly margins, as well as central ulceration. I would like to see if it's also tender or not, and the extent, if I can see through the, like to the fornices and the conjunctiva behind it.
Tamam.
And
Okay,
also,
so this is an important point I was going to mention. It's very important in any benign or malignant or any eyelid mass or cyst. You have to follow it and see the extension to the palpebral conjunctiva. It's very important, especially in malignant cases. Okay, what else?
and the lymph nodes. I would examine the lymph nodes around the area.
Excellent. Okay.
Especially the
Come on.
preauricular.
Okay, very nice. Excellent. But regarding the lymph node, what are the distribution of, or how does it drain? From the eyelid?
Okay, so the eyelid, I'll divide the eyelid. The upper 2/3 and the lower 1/3 mainly goes to the preauricular lymph node, while the medial aspect goes to the submandibular, I believe.
تمام.
Or submental.
Okay. Excellent. شكرا دكتورة. طيب. So these are points that you need to mention. So the active complaint, onset, and the progression. Anesthesia is very important. So always mention it. So frequent sun exposure, and all of the basal cell carcinoma I encountered were related to sun exposure. Immune suppression, radiation, smoking, human papilloma virus, genetic syndromes, the one that we mentioned, actinic keratosis. Also, of course, this is risk factors. You cannot list this in history, but you have to know that it's a precursor of squamous cell carcinoma, albinism, and xeroderma pigmentosa. Okay, as Dr. Abdullah mentioned, this is the lymphatic drainage. So the medial 1/3 and the lower 2/3 are drains to the submandibular. الباقي تروح البريوريكولار. Okay. Any junior resident R1 ولا R2 أو R1 يعني يكون فريش من البيسك ساينس كورس الباثولوجي. فيصل if you can moderate مو شايف الشاشة.
أبشر. So anyone would raise hand, or you want me to choose randomly?
Anyone, if anyone raises their hand, we can.
Dr. Abtihad is raising right now.
Sure. Okay, طيب. So can you أتوقع تبي تندم الدكتور. Nobody likes pathology. So can you just tell me, so we took a biopsy from the previous patient and it showed this. So can you tell me about this sign?
This sign, I think this is a picture of, I think it's an H&E stain for a nest of epithelial cells that show balustading. I'm not sure.
Excellent, inshallah. Okay, what does it mean, palisade? Oftentimes we memorize, remember last time I explained about molding. Many people, they just memorize molding, that it's associated with lymphoma. However, they don't know what it exactly means. So palisade, what does it mean?
I think it has something to the arrangement of cells. I'm not sure, actually.
Okay, so this is palisade. تمام? This is the palisade, and palisading means the configuration, how it surrounds the whole area. You can see the cells. Okay, so this is palisade. Okay, تمام. Can we have another junior? شكرا دكتور ابتهاج. If there is another junior. في دكتور عبد الرحمن كعكي. دكتور عبد الرحمن كعكي. طيب any other junior? على فكرة this discussion it's the main aim of this discussion is to have a systematic approach to the topic that we are discussing, as well as being a safe physician. وبنفس الوقت it will guide you how to answer in the oral exam. This is the time to discuss and even make mistakes. That's fine. Feel free to participate.
Dr. Abdurrahman doesn't have mic, unfortunately.
شلون معه؟ كل العالم كل الأجهزة صار فيها مايك. طيب اوكي عبد الرحمن خان.
السلام عليكم دكتور.
هلا كيف حالك؟
تمام الله يسلمك.
طيب عبد الرحمن, can you tell me about the types of basal cell carcinoma?
So the most common type is nodular basal cell carcinoma. Other types include morphiform, ulcerative, and pigmented.
Okay, and what's the most common type that we see in our population?
The most common type, I think, is nodular.
Generally, yes, but you can have nodular pigmented, because you can see that our population is not Caucasian. Okay, so you see commonly the pigmented type. So as you mentioned, so this is the most commonly you'll see carcinomas like this. So can you tell me why the medial canthus, if the basal cell carcinoma is located in the medial canthus, can you tell me why does it have the poorest prognosis?
I'm not sure, but is it because higher risk of spreading?
So what do you have here? You have close proximity to which structures?
We have the lacrimal drainage system.
Tamam. Okay. What else? So when you do DCR, you are in close proximity to which structure?
I'm not sure. I think maybe there is some blood vessels.
ENT. يلا هنت. شيء له علاقة بالENT.
The sinuses? Is it the sinuses?
So yeah, so it penetrates deep, so it has tendency to extend to the adjacent sinuses, and also it involves the canalicular system. Okay, shukran, Doctor. So basically, if the basal cell carcinoma, if it's confined because of the local spread, the typical local spread, you don't need to do workup. However, يمكن Dr. Abdurrahman, I showed you a case that we saw together. If it's fungating and it's very large and there is orbital extension, you need to do full workup with, of course, consultation with head and neck surgeon as well as oncologist. Tamam. Okay. Can we have another junior, R1 or R2? Can anyone raise their hand, please? غير اللي جاوبوا قبل. عبد الوهاب R2 ما أعرفه الحقيقة, بس if you can unmute.
السلام عليكم دكتور.
هلا حياك الله. كيف حالك عبد الوهاب؟
الحمد لله.
معلش ما عرفتك أنت which program؟
بروجرام الجنوب دكتور, South Region.
هلا حياك الله. طيب. So we'll go back to this mass. So how can you what is the surgical approach to this lesion? Let's say that you did incisional biopsy and it showed basal cell carcinoma. Now you will do the surgery. What's the surgical approach?
I think we will do the surgical excision, doctor, with maybe 3 to 4 millimeter safety margin.
Okay, tamam. Excellent. So 3 to 4 millimeter free margin. Okay. طيب. Let's say that this is the defect. What's the how would you close this? First of all, is this which lamella is violated or lost here?
I think both lamella, doctor, anterior and posterior.
Yes, this is the full thickness. I know it's silly question, but just to reiterate and emphasize this importance of both lamellae. Okay, so how would you close this?
والله يا دكتور ما قد سويتها دكتور صراحة.
So imagine this is a lid laceration. Okay, واحد جاك with an ER with the lid laceration with this similar. How would you close it? How can you close if you have a lid laceration? How can you close it?
والله I'm not sure الصراحة دكتور.
طيب زين الله يعافيك. So any other junior? I don't see a lot of cakish or KSU.
السلام عليكم.
ما ادري هل وصلهم
السلام عليكم.
هلا مهند. حياك الله.
دكتور معك المهند بقي أروان من KSU.
هلا حياك الله. طيب how would you close this?
According to the size of the lesion, in case of the lesion, I think there's a need for a tinsel flap, semicircular flap.
تنزل مرة واحدة.
If it's
let me tell you something. This is, let's say, 65 plus patient with the good amount of laxity. There is laxity of the lower lid. How would you close it?
lateral tarsal strip.
Now, if you want to bring this to this, صح?
First, direct closure.
So you will try direct closure.
Yes.
First, how would you do the direct closure? Which sutures will you use?
I think nylon or polyene suture. I'm not sure.
طيب, let's say that the direct closure didn't work. What will you do? There is still tension.
Lateral campectomy and then close it and reattach the lower lid.
Okay. طيب. شكرا دكتور. So this is just a video. So you can see you can close the lesion easily with direct closure. So this is they're using here silk 6/0 silk with vertical mattress. So far, then near. So you take a bite here, far, near. It's a vertical mattress. This will have good aversion. Then you close, they didn't show this, but you close the tarsus with 5/0 vicryl, and you can close the orbicularis in a buried manner, and then you close the skin. Okay? I know surgeons, I don't offer, sometimes I use vertical mattress, sometimes I don't. As long as you achieve vertical aversion, this is the most important thing. طيب. Okay, so any R3 or R4? Or let me choose Zubair. زبير سامبس.
الو.
هلا حياك.
السلام عليكم.
وعليكم السلام. طيب زبير, can you tell me other treatment modalities of basal cell carcinoma? Let's say that the 70 years old patient with a lot of comorbidities, you diagnose the patient to have basal cell carcinoma but refuse surgical intervention. So what other treatment modalities in mind?
Maybe radiotherapy.
Okay, so what are the indication and side effect of radiotherapy?
Indications if maybe there is metastasis and or extensive invasion to.
معلش تقدر تعلي صوتك معذر.
صوتي واضح؟
ما اسمعك زين. ايوه لا تعليه بس شوي.
ايوه اقول indications يعني اذا كان large in size وفي invasion underlying tissue you cannot excise the whole.
So to the bone, to the sinuses يعني.
Yes.
Okay. طيب, what are the side effects?
Side effects
of radiotherapy in the pre-orbital area. So you can just systematically mention this area, the lid margin, and etc.
Okay. Sorry, what do you mean?
So just tell me the side effect of radiotherapy. Let's say that you radiated this area. So what are the side effects? Possible side effects.
طيب can cause يعني secondary malignancies, cataract.
Okay. So just to make it easier for you, يعني start in the skin, lacrimal system, lid margin, conjunctiva, sclera, or cornea, lens, then fundus and optic disc. This is easier. You can just start externally until you reach your way to the optic nerve. So in the skin, sometimes it can cause, especially with the old modalities, unfortunately still I see patient post-radiotherapy to have contracture and shortening of anterior lamella. So this is one thing. Conjunctiva, you will have conjunctivalization and keratinization. Lacrimal system, also you have, you may have punctate stenosis or canalicular stenosis or even obstruction. Cornea, punctate erosion and keratopathy. Lens, cataract. If the patient is diabetic, the patient will be at risk to have what?
If he's diabetic.
And underwent radiation.
Ischemia.
Radiation retinopathy.
Radiation.
تمام. طيب. Okay. And of course optic neuropathy. تمام. What other modalities?
Radiotherapy. I'm thinking chemotherapy.
Topical or systemic?
Systemic. I'm not sure, but maybe cryotherapy also.
طيب other modalities?
That's all I can think
There is a new medication, I think Visomodegib or something, targeting the Hodgkin pathway, which is postulated or documented in new studies that it's being activated again on such malignancies.
Yes, excellent. I didn't write this down because I think it's too advanced to know, and I don't think you'll be asked about such drugs. There are many monoclonal antibodies that help in basal cell carcinoma and sebaceous cell carcinoma. So imicumod is one of the treatment modalities. It's a topical cream and interferon injection. Okay, so Zubair, الحين what are the advantages of surgical intervention versus these modalities? So you excised a mass here with surgical intervention, and in another patient you used, let's say, radiotherapy or مثلا imicumod. وش الفرق بينهم? Let's say both of them eradicated the mass, but what's the most important difference between them?
In the surgical, it's diagnostic and therapeutic.
Well, you can do incisional. No, I mean excisional removal versus these medication or other modalities. So would you know about the histological clearance of the tumor with these medication? You cannot.
No.
هذه بس نقطة يعني just to have in mind.
Yes,
تمام. Okay, I need a senior. في دكتورة اسمها مهيزة.
هلا أهلين.
هلا حياك الله. كيف حالك دكتورة؟
هلا الحمد لله طيبة.
طيب, let's go back to this. So let's say how would you close it step by step?
So we'll start with the margin so that we have a good anatomy and alignment at the and then we'll close the tarsus with long thread, leaving it outside, and then closure of the skin.
تمام. So lid margin, tarsus, then the anterior lamella. What I do usually, I start with the margin. Some people, they start with tarsus, but what I like to do is start with the margin, either vertical mattress or 3 sutures for each in the meibomian glands, gray line, and lashes. Depends on the patient. Sometimes I do vertical mattress alone. Then I do temporary suture. Why do I do that? In all lid reconstruction, I do temporary suture. I don't finalize the knot because I want to see the alignment.
Alignment.
Exactly. Did it align well or not? Even with years of experience, you may have more perfect alignment. So I always in lid reconstruction like to do temporary. Then when it is temporary and it's if it showed good alignment, I release it again. Then I put it on stretch. Tamam. So when I put it in stretch, you will see each layer easily. If this is the tarsus, you go to the tarsus, and I don't close the tarsus. So let's say that I took a suture here in the tarsus. I don't close it. I'll just make it loose and take a couple more. Then I finalize all the knots at once. Tamam. Okay, so let's say that direct closure manifest. What's the second option?
If the direct closure doesn't work, we can use graft, since it is full. Since it is both anterior and posterior. Well, before that, we actually mobilize the skin by creating a canthotomy or canthelysis. That will ease our closure.
So direct closure manifest, and you want to bring this to this. How can you put a graft and you have full thickness? So which graft you will apply? With a skin graft, still you have posterior lamella. So always repair posterior lamella before anterior lamella. So again, let's say direct closure didn't work.
If we want to bring the lateral edge to the medial edge, maybe we can mobilize it by canthotomy.
Okay, canthotomy and
canthelysis.
Okay, طيب. تمام. Okay, excellent. Thank you. So to summarize, you start with direct closure, a small defect. If it's not enough, you can add canthotomy and canthelysis. Okay. So let's see. Anyone can if anyone can join and raise their hand. Anyone? Okay. I'm gonna choose random names. في لا دلال خلاص جاوبتي الله يعافيك. I need someone else. ابتهاج برضو.
You want me to participate?
Okay, go ahead, Faisal. So this patient presented to your clinic.
With the
Faisal, you're second or third year?
Second year.
Okay. So the history taking, it's the same. We covered that. Just I need the brief description.
So this is a picture of a patient showing erythematous mass on the center of the lower eyelid with the nodular appearance. I cannot see any sign, obvious, maybe mild telangiectatic changes. I cannot appreciate any indurations or ulceration or bleeding or pigmentary changes around the lesion.
طيب, this area compared to this area, is there any difference?
It's like raised. There is like madarosis.
Excellent. So yeah, there is a loss of lashes. So this patient, he came with the recurrent appearance of this mass, comes and goes. So what do you think is the most likely diagnosis?
If I'm thinking of malignant diagnosis, I'll go with sebaceous.
Okay.
if other thing, there are many other inflammatory or infectious causes that can stimulate.
Excellent. So as you mentioned, again, it's very important to check the lymph node as well as the extension to the beyond the lid margin. Can you tell me about the anatomy of the lid margin from anterior to posterior? So what are the layers from here to here?
Different than the regular anatomy يعني ولا؟
لا the regular anatomy. So you start with eyelashes بعدين.
كم بدأ في eyelashes there is a gray line. Then there is the orifices for the meibomian glands. Then we go back to the conjunctiva.
Yeah, mucocutaneous junction. So this way you know the extension of any nevus or any cyst or mass by knowing this, by applying this anatomy. And also when you have lid malposition, either entropian or ectropian, you can quantify or know the severity of the degree of the lid malposition by applying this surface anatomy. So how would you manage? Let's say this is sebaceous cell carcinoma, and you took an incisional biopsy and it showed sebaceous cell carcinoma. So how will you manage it?
Removal, surgical excision.
Okay, how many millimeter of free margin?
1 to 2 millimeters of free margin.
1 to 2?
Yeah.
In basal cell carcinoma, we said 3 to 4. Sebaceous has more of, it's more malignant, I mean, in nature. So 1 to 2 is not that much.
But I think it's a deep lesion. If we made it a bigger removal, it would remove most of the eyelid.
So what?
Reconstruct.
So what? Even if you remove the whole lid, there are ways to reconstruct.
Okay.
So 1 to 2 millimeter, I don't think it's enough.
And as I recall, the Mohs resection surgery is not the best option for such lesions.
Yeah, بشكل عام textbook answer, yes. However, still, you can apply either Mohs, either frozen section, or paraffin.
Because it can miss many of the
yes.
invasions.
Everything can be missed with these techniques, and we're going to elaborate on that. But you can use what's available for you. The most commonly used is frozen section, as far as I know, in different hospitals. I mean, in Riyadh. Okay, so basal cell carcinoma or sebaceous squamous, you can remove it with the frozen section. Mohs is an option. In the literature, there are many institutes using different techniques. And again, it's different from the textbook answer. There is also paraffin section. There is a fast track paraffin section, but it's not available in all hospitals. Okay, so let's say that you removed it. How many millimeter of free margin?
As you say, 2 to 3.
Okay. So should be more than that. Yeah, 4 to 5. Okay. Yes. So let's say that you removed it. This is a different patient, but for the sake of discussion, this is the defect. How will you reconstruct this?
I think this is very large to be constructed with a direct closure.
Okay, so direct closure, canthomecantholysis is not an option here, you think?
Yeah.
Huh? طيب. Okay.
Maybe you can go for tinsel graft.
Is it called tinsel graft?
Well, I always mix it مع الهيوز. فالظاهر انه هيوز اجل.
لا, let's say other modalities than heels.
صراحة I'm not sure.
طيب. Okay, let's see anyone. في R3 أو R4. طيب, anyone raising their hand, please.
There are 2 residents raising, دكتور مشاعر خيال, دكتور محمد العتيبي.
طيب, دكتور محمد العتيبي.
السلام عليكم يعطيك العافية دكتور محمد.
هلا حياك الله. Which program دكتور؟
كيسي R4.
هلا حياك الله. طيب, how will you close this?
So as far as you know, if the defect is more than 50%, and we can use either the semicircular flap, which is called the tensile flap, or the tarsoconjunctival flap, which is the Hughes procedure, as Dr. mentioned.
So you start with tensile flap. How will you draw the tensile flap?
So it's semicircular. I will try to draw it here.
I don't think you can.
Okay.
ظهر لازم استخدم.
Okay, so it's semicircular means that it's going from the lateral canthus up a little bit, and then similar to what looks like to be a half circle going back.
So will this go like this?
No, the opposite way.
The opposite.
Yes.
Okay, excellent. طيب. And so you drew the tensile flap. Let's say just like this. Okay. Then you will incise the marked area and you undermine, and you bring this to this, صح?
Yeah. So the point of connection here is the lateral canthus. That should be separated. Otherwise, the flap will not mobilize. And then,
how will you separate it?
Doing like a regular canthotomy and cantholysis, and connecting the flap to the lid.
Or you'll do both canthotomy and cantholysis, not cantholysis alone.
Yeah, exactly. And then that will give space for the lateral lid like tissue to be pulled a little bit, and then will allow you to have a nice closure.
Okay, excellent. Are you interested in oculoplastics?
Wallahi, why not? We are open to suggestions, but I think I have other plans.
Okay, بس you answered it nicely, inshallah. طيب, so I cropped the image on purpose. So this is how to draw the tensile flap. So as you mentioned, if you have the lower lid, it should go the opposite direction. However, if you have the upper lid, it should go like this. And a very important point that you mentioned is you have to do canthotomy cantholysis. So as you can see here, so this is incision and undermining. However, we have fixation point here that you need to release, which is the lateral canthal tendon. So because you have a defect of both lamellae, you need to do
دكتور محمد بس الصوت ما ادري راح، ما ادري اذا انترنت كونكشن او مايك.
Okay, so I'm not sure what happened.
Yes, now it's clear.
Yeah, but I'm not sharing.
We can see the slides. I'm not sure about that.
Yeah, but I'm not sharing. I'm not sure what's happening. You can remove the co-host. شوف في co-host for participant. You can remove.
So you are the co-host. Okay.
No, because I cannot. You cannot start screen sharing while the other participant is sharing. If you can, okay. طيب, let me try again. Okay. هذا معلق السلايدز القديمة أصلا. Not sure what's happening. Okay, let me go out and I'm gonna log out وبدخل مرة ثانية. طيب.
Okay.
Okay, still the same problem. هي المشكلة إنه السلايد موجود and I cannot share my screen. This is not my screen. أيوة. Okay.
كيف الحين ضبط معك دكتور؟
لا لأنه يقول start screen sharing ما أدري من يقصد هنا. اوكي ناو ما ادري وش سويت بس الحين نفع. وش سويت بالضبط؟ ها؟ Now you can see the screen صح؟
كلير دكتور.
تمام.
بس انه مو بشغال السلايد بس we can see your screen.
اي تمام. So let's see just to test. You can see the dot.
Yeah, clear.
خلاص معناته we're back on track. طيب. اوكي. ثواني. Okay, so any fellow can participate regarding عشان هذا slide how to close it. You can hear me صح؟
كلير دكتور.
طيب اوكي if no fellow اذا في مثلا senior resident R4 R3 or R4 الدكتور مشاعل خيال let's ask دكتور مشاعل.
ايوه اهلا دكتور.
هلا حياك الله. طيب how do you close this defect? First of all this is defect of which lamella?
I believe this is anterior lamella, lower lid anterior lamella.
Okay, so how will you close it?
We can use a skin graft.
Okay. Other than skin graft, if you want to close it with a flap, how will you close it? So as we mentioned that the best thing to do is to close it horizontally to avoid vertical tension.
Exactly, yes.
How will you close it horizontally? So this is an old patient and you can see that most likely the patient will have significant laxity. So how would you close it?
Can we try, I'm not sure, Z-plasty, or it doesn't work here?
So Z-plasty is more of if you have a contracture, a vertical contracture that you want to shift it to a horizontal one.
Yes, yeah.
Intact lamella. It's not, this is a defect, a different thing.
Okay.
So what's the typical incision in the eyelid? So if we want to incise the eyelid, let's say an anterior approach of blepharoplasty, what's the approach? How will you mark it? Where is the marking if you want to do
You mean 10 millimeter above the eyelid margin?
لا. We're talking about the lower lid margin. So you want to do blepharoplasty. How would you mark the patient? Or you want to do orbitotomy or whatever, any kind of surgery in the lower lid?
Yeah, subciliary approach.
So yeah, subciliary. Okay. So it depends on the laxity of the patient. So you can mark it subciliary, and you can see you can simulate the laugh lines and the laugh wrinkles. So you can camouflage the incision. So basically, with the crow's feet and the adjacent wrinkles, you can mark this area. Then you can do here also, just following the relaxed tension line. Then you do undermining. Then you can bring this to here, bring this to here. This is if you want to do a flap. That's why I wanted the fellow to answer this, because it's more of an advanced one. So let's say that you chose a skin graft. What are the areas that you can harvest from?
Behind the ears, preauricular, subclavicular.
Okay.
These are the options.
في different options. You can see here something. They already موجودة. What else? So you mentioned preauricular, you said?
Yes.
Supraclavicular? Okay, 2 more or 3 more. So pre and post auricular. Okay.
Okay,
so
yes.
We finished from that area. Supraclavicular is 1. There are 2 more. Anyone? Anyone can mention?
The writing medial upper arm.
So regardless, the upper middle part of the upper arm and the upper lid. Why is this sutured? نفس السيرجن أخذ skin graft من هنا. Either the same one or the arguably there is another intervention that you can do. Again, this is more of a fellow. You can do like this and do like a marking of blepharoplasty, and you can just do transitional. But this is more of an advanced technique and may cause webbing here. It's more suitable in these to do this technique in this area to avoid such webbing. Okay, so again, so we have the upper lid, either the same lid margin or the either the same side or the other side, pre and post auricular, supraclavicular, and upper arm. Honestly, I mostly do either this or this. I only go to these areas in traumatic cases or in ichthyosis cases or burn patient, traumatic cases when I don't have. I do it a lot in National Guard because I deal with a lot of burn and traumatic patient where they have unfortunately lost the integrity of these structures. Okay, so to summarize what we have so far. So if you have less than a third of the defect, direct closure, if it's tight, still tight, you can do canthotomy and cantholysis. Tensile flap for third to half for moderate defect. Just one other thing. If you a tensile flap, if you have full thickness anterior and posterior lamella, you have to do canthotomy cantholysis to drag this to here. However, if you have only anterior lamella and you want to do tensile flap, it's an option. And internal cantholysis should be enough to do. Again, this is advanced for fellow. I'm not sure if there are fellows in the audience, but just to mention these.
دكتور I have a question الله يعافيك على ال previous case اللي قبل هذه.
This one?
If it's anterior lamella, and let's say we are disregarding the cosmetic reason or we are on a tertiary place that we don't have any, or the patient is refusing. can we rely on granulation for if we leave this defect, would it heal with granulation or not?
You can, but you need to watch the patient carefully. This is a large defect to leave for granulation. There is a technique called laissez-faire technique, and basically laissez-faire is you remove the mass and you just leave it. It's very common to use in the medial canthus, laissez-faire technique. However, you need to follow the patient closely to avoid, just to check if there is any lid malposition. If you did it in the medial canthus, you need to check any webbing or dragging and loss of integrity of the medial canthus. So yes, laissez-faire technique can be used.
الله يعطيك العافية تسلم.
طيب. Okay. So how can we approach? على فكرة فيصل, I didn't see a lot of Cakish residents. Did they receive invitation?
It has been shared to all the residents, yes.
Okay. طيب في دكتور عمر قيراط.
السلام عليكم.
حياك الله.
حياك الله.
كيف حالك دكتور عمر؟ طيب.
الحمد لله. كيف حالك دكتور؟
الله يرضى عليك. طيب بالنسبة للسبيشيس سيل كارسينوما, how would you treat sebaceous cell carcinoma?
Okay. Hello.
معك. So let's say that you did incisional biopsy to this patient.
Yes, doctor.
And you have diagnosed the patient to have sebaceous cell carcinoma. So how will you treat it?
Okay, you need to do first of all investigation to make sure that there is no metastasis.
تمام.
Okay, طبعا after full examination and history and all the pre-clinic work, then to investigate the patient to make sure that there is no metastasis. And then I need to take the patient for surgery for excisional biopsy or excision with free margin and excision under frozen section with free margin.
طيب. Okay. Then what else? We're not going to talk reconstruction. So let's say excisional biopsy. 3 is not much, so I would do 4 to 5 free margin. What else? So this patient, you can see there is tarsal involvement, there is bulbar conjunctiva. So with excisional biopsy, what else you will do?
I think this patient needs to be augmented with either with radiotherapy or
لا قبل diagnostic procedure مع excisional biopsy.
I am not sure really, doctor.
طيب اوكي. محمد بن منيع. شكرا دكتور عمر.
العفو. حياك.
محمد بن منيع.
السلام عليكم.
وعليكم السلام. تاخرت ما شفتك قبل.
معليش كنت مشغول انا اسف.
طيب. So again,
maybe map biopsy in this situation to make sure that margins.
So why would you consider map biopsy?
To make sure that all the margins are free of malignancy.
Do you know how to do it? What's the technique of biopsy?
You told us once, but I forgot. You said 5. We take 5 biopsies, I believe, from the upper leg.
Okay. So adjunctive therapy with the, let's say, excision with map biopsy. What other adjunctive treatment that you know of that you can apply in sebaceous cell carcinoma?
Maybe radiotherapy after the complete excision.
طيب. What else?
Not sure if brachy applies in this situation or not.
You mean cryotherapy?
Yeah, cryo, sorry.
Right. You can cryotherapy, you can do it yourself. Okay. To the bulbar conjunctiva. Okay, what else?
Mitomycin.
Systemic or topical?
No, topical.
Why did you mention mitomycin? You came across something, any study or something?
No. I just thought it might be used as like the
So, okay.
conjunctival.
So if you have a positive map biopsy, you would do mitomycin C, topical mitomycin. Okay, fair enough. What else?
No, I'm not sure, I think.
So what are the poor prognostic factors in sebaceous cell carcinoma?
Truncular involvement.
Okay.
If we have metastasis.
Okay.
If the distribution is involving the bulbar and palpebral conjunctiva, if there is a recurrence,
okay,
more than 10 millimeter size.
Okay, good. And any invasion, either orbital invasion or lymphatic or vascular. So again, I try to make this systematic as possible. So you do an incisional biopsy or sheath biopsy. You confirm the diagnosis. Then you do an excision with 5 millimeter free margin. In the exam, you can mention map biopsy only if they asked about map biopsy. Some surgeons, they don't do it. If you have a tarsal conjunctiva or full thickness involvement or bulbar conjunctival involvement, you have to do it. However, sometimes sebaceous cell carcinoma, like the picture I showed you, it's only localized in the anterior part of the lid. So some surgeons, they don't do map biopsy for such lesion. Not this picture, the one I showed you before. Okay. Adjunctive therapy, cryotherapy, radiotherapy, chemotherapy. Chemotherapy, systemic, or topical. These are radio and chemo reserved for advanced cases. These are the prognostic factors, poor prognostic factors. So this is the map biopsy. So this is by Carol Shields. It's 18. So you have upper and lower. So you have 6 for the palpebral, or sorry, palpebral, and 6 for the fornicial, and 6 for the bulbar conjunctiva. And you need to label it and plot it very carefully for the pathologist to read. If you have a similar mass like this one, a very easy tool and handy tool that I use quite often is punch biopsy. Dr. Mshal, the previous patient that I showed you, she did punch biopsy nicely. طيب. الحديث يطول مرة في sebaceous cell carcinoma. I urge you to read this nice review of sebaceous cell carcinoma. It summarizes nicely the treatment modalities. However, in oral exam, you just say excisional biopsy, followed by, after you confirm the diagnosis, you do excisional biopsy and mention map biopsy if there is obvious full thickness or bulbar conjunctiva involvement, mention it. So, Mohammed, why would you do map biopsy for sebaceous cell carcinoma? Why not do it for, let's say, basal cell carcinoma? وش معنى يعني sebaceous cell carcinoma?
Because of the type of metastasis in sebaceous cell carcinoma. It has skip areas.
Skip areas, what else? So again, I always emphasize about key and buzzwords for the oral exam to show that you know what you're talking about. So the spread, the typical spread of sebaceous cell carcinoma is what?
Pagetoid spread.
So pagetoid, that's why map biopsy. So please review this article, it's very nice. Just to summarize, if you have T2B or more, or full thickness, you need to involve a head and neck surgeon and oncologist to see if you need to do a sentinel lymph node biopsy or not. T3A, as you can see, any preneural or invasion of ocular or orbital structure. This has poor prognosis and survival rate, and also you would consider exenteration in these cases. Okay. Any question regarding sebaceous cell carcinoma before we move on? بس قبل typical mitomycin C that you mentioned, there is a good case series by Carol Shields or Shields and Shields. They studied typical mitomycin C, and after they removed the lid part and the bulbar conjunctiva, they applied a course of topical mitomycin C until complete clinical resolution. تمام. Any question before we move on to the next topic? If anyone asks, أفضل إنه you ask unmute because I cannot see the chat.
Dr. Abtaj asking about shape biopsy. Is it enough on the sebaceous cell carcinoma?
It's enough. However, there's no harm of taking multiple biopsies at the same time. So you can do incision, or you can do punch. I usually do a lot of punch biopsies. And when you do punch biopsy, it's good to take the normal as well as the abnormal looking tissue. So the pathologist will know the difference and the transition between tissues. Shave excision, if you want to do it alone, try not to crush the of course, when I say shave excision, I mean the lid margin. So try not to crush the mass. طيب. If anyone has a question, you can just unmute.
Doctor, I have a question.
Yes.
When do we do orbital exenteration? In which cases we decide for exenteration?
Yeah, so this is a very tough one because there are different scenarios. So you can, if you have a patient with, let's say, T3A or more, with positive lymph nodes and metastasis. So the oncologist may ask for exenteration because you want to decrease the tumor load and at the same time help the adjunctive therapy. However, such aggressive surgery that may affect the patient psychologically will not do much for the overall survival. So it depends. The typical answer is if you have an involvement of ocular or orbital structure with preneural invasion, you should consider exenteration. Let's say the patient refused. So if the patient refused, this is a rare disease. So there is no clear answer. However, there are some, there is a good series, I think, how many patients? Maybe, not sure, either 15 or 20 patients, where they did incisional biopsy, then they started systemic chemotherapy, cisplatin, I think, and vincristine. I'm not sure about the cycle, and it's removed. It gave a very nice result that even the mass has decreased in size, about 70 to 80%. So when they reached that stage, they did excisional biopsy. That made the surgery much easier, followed by very close follow-up. So it's not an easy answer. For me, it should be individualized.
Mm-hmm.
So, but the typical answer is this one, T3A, okay, yes. or worse, okay.
Okay.
If you're dealing from this downward, you should involve oncologist, head and neck surgeon, and also radiologist, okay, because sometimes sentinel lymph node biopsy, the patient, they refuse to undergo sentinel lymph node biopsy. So you can arguably elect to follow it up with PET scan or serial MRI. Okay, so just to summarize, and again, this is more of a fellow discussion or points. So if you have this or worse, you should consider exenteration. But in my practice, I would really discuss it thoroughly with the patient and involve an oncologist. Being in a very nice multidisciplinary hospital like National Guard, I have the luxury to discuss with the oncologist. They help me a lot in these cases. Okay, any other question?
Thank you.
Okay. So this is a video just to show you how to take the biopsies. So this is the shave excision. You can see the lid margin and the lower lid. Always, you can see how they injected. They injected horizontally. Always the resident who rotate with me, I tell them to inject this way to avoid open globe injury. Why? Because if the patient moves, the needle will not be perpendicular to the globe. It will be parallel. So after that, they just shave it like this. I do this a lot for cosmetic reason. You can notice that they did electrolysis here. I never do electrolysis. I'm going to mention that later, why I don't do it. Punch biopsy, again, this is a very nice one. You can use the same as the one that dermatologists use. You can use 3 millimeter or above. That's fine. Again, see how they injected. So you can see, Dr. Mshahri, remember you did one like this. You go perpendicular. If you remember, Dr. Mshahri, it goes really deep without knowing.
Yes.
Yeah, so you have to be very careful. Huh? If you're perpendicular to the globe, be careful. But it's a very nice procedure. Here you can do electrolysis easily and safely. So just a couple of points regarding these biopsies. Oops. Okay. Regarding punch biopsy, it's very handy. You have to learn how to do it. It's very easy. If you see a video and apply it, it's very easy to learn. I did it a lot on dementic patients where they are not cooperative, and I just need to do it quickly. It's a very nice way to do biopsy. Regarding shave excision, Dr. Ibrahim Mansour, remember I showed him how I do it. So I do a traction suture and I flip the lid without touching or manipulating the cyst itself, because I don't want to induce a crush artifact. طيب. Let's see. So are we good on time? We'll continue. باقي تقريبا like 15 slides. So نكمل فيصل.
It's okay for me. اللي رايحك دكتور.
تمام. طيب. Okay. R3 or R4 أي حد. خل دكتور إبراهيم منصور. A lot of names I don't recognize. iPhone, iPad. I can't choose an iPad. ما أدري من هذا الشخص. طيب إبراهيم.
ألو. هلا دكتور.
هلا حياك الله.
حياك الله.
طيب. So خلاص we covered the history taking. We covered the examination. So how do you approach this surgically?
Before I have to make sure, usually such a lesion near to the medial canthus, I would make sure about the patency of the lacrimal system.
شوف في النيوبلازم this is when you do a full removal. So let's start first. What's the first step to do? يعني نمشي واحدة واحدة.
Okay, I would take an incisional biopsy.
تمام.
Yes.
Okay, so it showed squamous cell carcinoma. How would you remove this?
It's a large.
Yes.
Yeah, it's a large tumor. So I will do a surgical resection with 3 to 4 millimeter free margin. And yeah, regarding the reconstruction, I will have a big defect.
Mm-hmm.
Yeah.
Okay, so this is the defect. How would you How would you surgically treat it?
So I can see anterior and posterior lamellae defects. So
Yes.
yeah, so I will need a flap and a graft for such defect.
Tamam.
I might consider taking the flap from the upper eyelid. And
طيب, what's the name of the flap?
Higgs flap.
Hughes flap.
Hughes, sorry, Hughes.
Okay. So how do you reconstruct using Hughes flaps? What are the steps? They will not ask you for the exam about Hughes flap, just for the sake of discussion. And since we have fellows in the audience, how will you do Hughes flap?
Not sure, صراحة. I'm not aware of the steps.
طيب, any volunteer? Just كده quick steps. يعني again, this is not as a resident, they will not ask you.
What I know is we have to take a tarsal conjunctival flap and from the upper eyelid.
Okay. طيب, as you mentioned, so how many millimeter you will leave? يعني من الليد margin and superiorly, how many millimeter you will leave?
2 millimeter.
لا أكثر, يعني ممكن 4 millimeter.
From the eyelid margin. Okay.
So this is superior, huh? Don't get confused because you flipped the lid. Okay, so this is superior and this is inferior, but because you flipped it, you get confused. So 4 millimeter because you want to leave for the upper lid some tarsus.
Yeah.
Okay, then you dissect superiorly. If you can remove, dissect only conjunctiva without molar, that would be nice. Then you suture it. Of course, you can see here, they took the defect from here to here. So they can cover the whole defect.
I see.
طيب. Okay, so now you are left now with the anterior lamella. So how can you reconstruct the anterior lamella?
Again, we need a skin graft.
Okay.
So we, as we mentioned, we have multiple areas to take the skin graft from.
تمام.
Yeah.
Excellent. You can see that the eyelid is marked. Again, here, if the patient is elderly, there is a nice way to take a flap. So as if you're marking a blepharoplasty. Then you take a good amount of skin. Then when you dissect in this area and undermine, you can flip it and just suture it here. Okay? I like doing this technique because this gives flap over flap, and it almost never shrink, not like a graft.
Okay.
Here they applied skin graft. Of course, it's much easier to do. تمام. If there is any fellow who wants to just كده يعني friendly discussion, how would you close this? أحد الfellows. No one. Okay.
Maybe hard palate graft, doctor. I'm not sure.
It's okay. This is advanced. We'll skip it since no one is participating. طيب. So squamous cell carcinoma is nodular ulcerative. You may heard about keratocanthoma. It's a precursor, so you should treat it as if you're dealing with squamous cell carcinoma. And preneural invasion is predominant in these lesions. And so management, excision under frozen section, 3 to 4 millimeter free margin. Chemoradiotherapy, again, the same indication as before. If you have orbital invasion, the patient is not fit for OR. There's if the patient refused, it's now it's overlapping with other tumors. طيب, again, to summarize, it's the same as the basal cell carcinoma. So it's very important. You have chest CT, abdominal CT, PET scan, LFT and lymph node. Lymph node and PET scan, it's redundant. You can check lymph node by doing PET scan, and you can do MRI. طيب, first year resident دكتور عبد الله بلالي.
يا هلا دكتور.
كيف حالك؟ طيب.
خير.
طيب. I need the spot diagnosis.
Okay, this is
spot diagnosis. What's the diagnosis?
Is it due to burn? I'm not sure صراحة.
لا.
صراحة.
Anyone else can join in and say the spot diagnosis? Okay, excellent. Can you tell me about the mode of inheritance of xeroderma?
I think it is autosomal recessive.
Yes, this is a correct answer. Try to avoid the word or the phrase I think in oral exam, okay?
Okay.
طيب, excellent. And what's the main pathology in such
and xeroderma pigmentosum, there's failure of DNA repair.
So there is a defect in DNA repair. And why is these patients they are at risk of which kind of lesions?
They are at risk for conjunctival malignancies, squamous cell carcinoma, and also melanoma.
So conjunctival, you said. What about eyelid, meaning skin malignancies?
I think they're also at risk for skin malignancies, especially if there is a skin exposure, like basal cell carcinoma.
So they are at risk of different cutaneous cancers. Okay, good. So any question, Ilan? If anyone has a question, please unmute.
دكتور محمد السلام عليكم.
هلا نواف.
دكتور بخصوص الهيوز فلاب انا اعرف انها تكون على several weeks والريليس يصير through stages. ف خلال كم تشيلها دكتور تبدا تشيلها؟
So it depends. If you have so the typical answer is 4 to 6 weeks. Some people they even divide it after 2 weeks. So 4 to 6 weeks is the safe answer. Okay. However, it differs. I usually depend on whether if I have a flab on flab, I can divide it much earlier. However, if I use the skin graft, I may leave it a little bit longer to
vascularize.
Exactly, to make sure that the skin graft has been vascularized enough.
Okay. ما يعطيك العافية دكتور. شكرا جزيلا.
Any other questions? طيب. Okay, we'll go to the next slide. Okay. Yeah, I need the senior Dr. Raghad Rashid. I noticed joint program are predominantly here. غريب.
السلام عليكم.
Hello, عليكم السلام. طيب. So we mentioned this already. تمام. طيب, how would you reconstruct this defect?
So this is upper lid defect, and it is large, more than 50% of the eyelid. So we will do cutler beard procedure.
Excellent. So can you just again?
From the lower lid.
So the steps, I don't think anyone will go through the steps. So what are the steps of cutler beard?
As far as I know, it is full thickness. It is like use procedure, but it's full thickness from the lower lid. But as for the steps, I actually do not know.
I don't expect steps to here, more of a fellow base. طيب. So as you can see, there is a full defect and incision here. you take a full thickness incision here. How many millimeter?
4 to 6 millimeter.
So why 4? Why not 3? Why not 2? Why 4 to 5 millimeter?
Because of the blood supply, the marginal.
Marginal is 2 millimeter in the below the lid margin. It's a different arcade. Which one?
Peripheral.
Exactly.
Okay.
So that's why you do 4 millimeter. There are any fellows. You may be familiar with Weiss procedure for entropion. The same rationale. When you do full thickness and Weiss procedure, it has the same rationale to avoid injuring the arcade, peripheral arcade. So after incision, you undermine here the post orbicularis and preseptal. Then you drag it from under this defect and you suture it to the
upper lid.
Upper lid. So you suture conjunctiva to conjunctiva, and the retractor, it's better to lower lid retractor, better to disinsert it. However, some people they do. I don't think it makes any difference, although some say that it may cause retraction in the upper lid. I'm not sure. Then orbicularis to orbicularis, then skin to skin. Okay, so this is called Cutler beard. What about modified Cutler beard? Is there any difference? So what did we replace here? Did we replace the conjunctiva, tamam, and we replaced the skin, and we replaced the orbicularis. So we left one tissue behind here that we didn't replace. What is it?
Tarsus.
Yes. So modified Cutler beard is replacing the tarsus. So what? How can you replace the tarsus? You only have a graft, okay? Because you cannot take it from the lower lid. So you replaced all. Hey, sorry.
From the mouth.
Mouth is a mucous membrane graft, so it can replace conjunctiva. It will not replace tarsus. Tarsus is a dense connective tissue. So how can you replace it? What are the donor sites?
Ears, cartilage.
So ear cartilage is one.
Oh, palate.
Hard palate is one. Okay. So this is autogenous, right?
Yes.
Okay. What else? Tumor.
Sclera.
Autogenous. So you have hard palate, you have ear cartilage, you have also nasal septum, and you have the contralateral tarsus, صح?
Yes.
Contralateral upper tarsus. Okay, excellent. طيب, what about allogenic? You mentioned sclera, صح?
Yes.
طيب. What else? ما قصرتي ترى. Let's have another one. Any senior can mention other materials. So we have 1, 2, 3, 4 more slides and we're done. Okay, so other materials you have allogenic like sclera. I use sclera quite often. We did a case, Dr. Mshahaj saw a case of facial palsy. So other than sclera, you can use synthetic material like alloderm. But if you use any material or any graft other than hard palate, you need to cover it with a conjunctiva, because remember in the slide of reconstruction goals that we need to have a smooth posterior surface. This will not be achieved illa bil tarsus and the hard palate. Okay, I see some people joining, so I think it's too late. No, we already have a couple of slides. So this is the Cutler beard. So you can see it sliding below. And this is how to divide it later. mustardy cheek is also, you have to know it, بس عشان you have to mention it and you have to know about it regarding the exam. طيب. So textbook answer, the green one you can do more surgery, the red one you cannot do more surgery. I didn't cover melanoma because I don't think it's an oral exam topic and it's not common in our population. So this is to summarize, we covered all the, so to summarize that, if you have a lower lid defect, it's Hughes. If you have an upper lid defect, you have Cutler beard. Tamam? Okay, this is from Nirad. I urge you to read it. It's a very nice, concise summary about the, if you read it today, I'm sure that you're going to be a master in lid reconstruction. Okay? Of course, there are some ways that some reconstruction I didn't mention, like the median forehead flap, because it's more of a fellow level question. Tamam. Any questions? Anyone has any questions? طيب ان شاء الله هلا تفضل.
دكتور ممكن لهن دكتور الله يسعدك كان
معليش who's this؟
معك عبد الوهاب دكتور عبد الوهاب.
Which program؟
South Region دكتور.
الله يحييك.
الله يسعدك. طلعت معك قبل شوي دكتور.
اي
دايركت كلوجر دكتور.
اي وش في دايركت كلوجر؟
Can you repeat دكتور please the steps of direct closure?
So you can check Wells manual. It's very nice. So I start with the lid margin. So I start with the lid margin. You can do vertical mattress or different interrupted sutures, like you do a gray line and you do a Meibomian one and the lash. Then I do temporary tie and stretch the lid. Then I close the tarsus, followed by orbicularis and skin. Then I finalize the lid margin suture, and I bring the lid margin suture down, or with the upper lid up, and tie it under one of the skin suture, so the knot will not rub against the cornea. Clear?
Clear دكتور.
تمام. طيب يعطيكم العافية. إن شاء الله إنكم استفدتوا.
تسلم.
تمام يلا good luck. نشوفكم على خير إن شاء الله.